Good afternoon, Dr. P. This is Marcela Garza, the nurse caring for a patient on the medical surgical floor. I'm calling to update you on a new admit from post-op following a partial colectomy earlier today. His name is Mr. JP, a 76-year-old male, and he arrived on the floor around 5:30 p.m. Since arrival, we've noted several concerns that I'd like to bring up to your attention, including a decreased level of conscious, severe pain, and urinary complications involving hematuria and clotting. Mr. JP is a 76-year-old male with history of diverticulitis who underwent a partial colon resection earlier today. Per the OR notes, the surgery was without intraoperative complications, and he was transferred to the post-op recovering and monitoring. His past medical history includes hypertension, mild chronic kidney disease, benign prostate hyperplasia, hospitalization for a UTI about 2 months ago. He has no known drug allergies and currently not on pain medications due to decreased level of conscious. Upon arrival to the unit, we noted that he was minimally responsive. He had a LOC of ×2, respond to verbal stimuli, and roused with tactile stimulation. This was a change from the post-op PACU notes, which was documented earlier, and oriented ×3. Pain was assessed during the numerical pain scale. Although his level of conscious was reduced, he grimaced during movement, and when asked, he was able to indicate that his pain was a 9 out of 10 in the lower abdomen and pelvic region. He was also guarding and extremely restless. Assessments was a blood pressure of 98/56, heart rate of 108, respirations of 22 beats per minute, temp of 99.6, and O2 stats of 97 on room air. His skin was pale, slightly diaphoretic. His abdomen was firm with tenderness in the lower quadrants. Incision sites were clean and intact and healing. Bowel sounds were hyperactive. He also voiced an urge to void, but stated he was unable to. And when asked with family members, he stated that they stated that he always had difficulty initiating voiding. A bladder scan showed approximately greater than 250 mLs of urine, so we proceeded with a straight catheter. Upon insertion, we noticed immediate hematuria and clotting. He was experiencing pain at the moment, and as we irrigated the catheter to relieve any obstruction, the hematuria persisted. This was concerning, so we escalated the issue to our nurse manager. With approval, we transitioned the patient to a 3-way continuous bladder irrigation setup with the Foley catheter to prevent further clots, retention, and obstructions. After starting the continuous irrigation, output remains blood tinged with ongoing clotting, though less obstructive. We documented hourly outputs and have initiated intake and output monitoring. Mr. JP remains responsive. Level of conscious and pain behavior warranted a continuous monitoring and possible reassessment of pain control strategies. We recommend for this client, we are concerned about the possible post-op complications such as UTI, bladder trauma, or from catheterization, or delayed bleeding from surgery. Given the persistent hematuria and decreased level of conscious, I recommend the following. Immediate consult with urology to evaluate the source of bleeding and guide further management of the continuous bladder. Labs, order CBC, coagulation panel, creatinine, and urine analysis with culture to assess for anemia, clotting issues, or infection. Imaging, consider a bladder ultrasound or CT scan to rule out injury or internal bleeding. Pain management, possibly a PCA to be initiated, or IV or PEO medications. Monitoring recommended every 1 hour with vital signs, strict eye and nose, and neurological checks until level of consciousness improves. Foley care, continuous bladder irrigation, and monitor output for color and clarity, and escalate continuous bladder irrigation if clots remain the same. We would like to continue monitoring closely, but your input and evaluation would be greatly appreciated to help determine the next steps and rule out any surgical or urological complications. Would you like me to page your urology, or will you be placing the consult?